Hello, so today I'm going to be presenting my case study on a pregnant woman that I came across during my rotation at the WIC clinic. A general outline of my presentation will be following the nutrition care process. So first I will be discussing my assessment of the client, diagnoses that I come up with for my client after assessing her, an intervention that I would use on my client, and then how I would monitor and evaluate the progress of the intervention. So for the assessment, my client was a 32-year-old Middle Eastern woman. She was married. This was her first child that she was pregnant with. She was at 31 weeks gestation, and some of her symptoms and complaints were just being newly diagnosed with gestational diabetes and just not understanding how to really cope with it. Her anthropometric, she was 5'5". Her pre-pregnancy body weight was 160 pounds. And her ideal body weight was calculated to be 125 pounds with a ideal body weight percentage of 123% of her ideal body weight, which she was put at overweight, BMI of 26.6. Her weight gain thus far during pregnancy has been 20 pounds, and her overall goal of weight gain is no more than 25 pounds due to her overweight pre-pregnancy BMI, so she doesn't have that many weeks left to go, and her goal would be to gain no more than 5 pounds, but as we keep going, you can see on her gestational chart, if you look at kind of the path that she should be gaining weight, she falls where that red dot is, and for her BMI of 26.6, looking at the key there, the smaller dotted lines are kind of where she should be falling between. So she is a little bit above that. So, but as long as she just kind of doesn't increase too much at this point, and just kind of steadily keeps gaining weight until the very end, she's okay, but she does fall above that line, that ideal weight gain range right now. Looking at her nutrition-related history and intake, she doesn't have any allergies or chewing and swallowing problems that can be preventing her from obtaining what she needs. She does have some constipation that she has complained about, which is not uncommon with pregnancy because of the fluid shifts, and also I'm going to discuss kind of the vitamin she's on that's also a side effect of that. And her recent changes in eating habits, because she's a new diabetic, she stated watching her grain intake because she was instructed by her physician to limit bread and cookies and cakes and things like that. So she's been kind of trying to avoid most of that. Her appetite is good, and her food preferences are cheese, fish, chicken, and desserts, which are making it very difficult for her to kind of cut back on the refined grains, or just grains in general. So if I were to conduct a 24-hour recall, these are the questions that I would consider. First, I would ask her to describe a typical day just to get an idea of her schedule, what I'm working with, if she's really busy, if there's anything throughout the day where she's eating that can be adjusted, or if there's some areas that can use improvement, and just kind of giving me an idea of what she has going on. And then how often she snacks, just to see again if she's eating more meals or is she more snacking throughout the day, and what types of snacks she's eating, to see if we can work on anything related to that. And how often she monitors her blood sugar would be another question, because right now it's really critical that she makes sure she monitors that. And then who does her cooking, because that's something that's not in her control. So medications and lab values, she isn't on any medications at the time. She's not on any glucose medications to kind of help regulate that, but she is taking a prenatal vitamin right now. And side effects are low appetite and gastrointestinal discomfort. So she is experiencing some constipation, which is a side effect of that. And so we're going to try to work on that with her. The lab value, so only had the hemoglobin, which is at 12 grams per deciliter, which is within the normal range. So I think her prenatal vitamin is definitely helping her with that, because at this point she is limiting her grain intake, which a lot of the times are fortified with iron. So thus she is at risk of iron deficiency, because at the same time being pregnant and sharing the iron with a growing infant, she is restricting her diet. So we need to work on that and make sure she's still getting grains that she needs. So for pregnancy, there are a lot of things that kind of happen. So I'm going to go through the pathophysiology a little bit here. But first, there's a lot of hormonal changes. So there's increases in progesterone and estrogen and also HCG, which is first brought on by the placenta. So this can be seen, high levels of this can be seen during as soon as the first week of pregnancy, which is oftentimes how they are able to tell if a woman is pregnant with this hormone present. And there's also a lot of cardiac and renal changes that occur. There's an increase in cardiac output to increase blood flow to the fetus. There's also renal changes, and blood pressure regulation are impaired, which is, I think, why a lot of times women might experience preeclampsia, because there's just a lot going on. And then the flow of urine to the bladder is also impaired, so it's common that pregnant women oftentimes are frequently going to the bathroom, and not only is the flow of urine to the bladder impaired because of the pressure, that is why, and all these other changes are happening, that is why the women experience these symptoms. Going forward, there's also hematologic changes, so there's increases in plasma and blood cells for adequate blood supply to the fetus and the mother, and this can cause dilution in the blood and result in anemia. And there's also gastrointestinal changes, so the growing fetus puts pressure on the organs, like I mentioned before, and women can experience symptoms of constipation, gallstones, and heartburn. And we know the client so far, she has experienced constipation. That is common. Now I'm going to be discussing the pathophysiology of labor. So there are 3 stages, and in the first stage, oxytocin is produced by the posterior pituitary to stimulate labor and initiate contractions, as well as the prostaglandins, and the myometrium, which is the smooth muscle in the uterus, and the cervix begin to stretch. There are 3 phases within this stage, but in the latent phase, this is the earliest stage of labor, and it's the longest and the least intense. So contractions are between 5 to 20 minutes apart, but as labor goes on, it goes into the active phase, which is where the cervix begins to dilate. Contractions become closer, they're 3 to 4 minutes apart, and they also become stronger and more painful. And lastly, in the transition phase, the cervix is fully dilated, and the contractions are short and strong and occur every 60 to 90 seconds. During delivery, stage 2 happens, so this is where the cervix begins to open and when the mother feels the urge to push, which is pushing the baby through the birth canal. And as the woman does that, the baby's head begins to crown and become visible, and the duration of this is between 30 minutes to 2 hours, and oftentimes for first-time births for a mother, it's usually in the longer side, so up to 2 hours. At stage 3 is just the delivery of the placenta that has been supplying the baby with all the nutrients and everything it needs through the birth canal. So now I'm going to be discussing her medical condition, which was just gestational diabetes, which is an impaired glucose tolerance occurring during pregnancy. And the risk factors of this are obesity, advanced maternal age, and family history. She was overweight, which definitely put her at risk before pregnancy. She is a little bit older for her age, and I'm not sure if she had any family history, but if she did, that would definitely increase her risk as well. So why does gestational diabetes occur? So like I mentioned before, there's a lot of physiological changes and adaptations that occur with a new something that's growing within the body. So there's a lot of renal and hematological, respiratory, and metabolic changes. There's changes in hormones that promote insulin resistance. There's increases in estrogen, progesterone, leptin, cortisol, placental growth hormone, which all can promote that insulin resistance and also cause blood glucose to transport to the placenta and rise. And so with normal pregnancy, there's hypertrophy and hyperplasia of the pancreatic beta cells, which we know are what secrete insulin. And unfortunately, with gestational diabetes, this is what is impaired and why that glucose can't get controlled. I calculated the nutritional needs and macronutrients for my client and found that using Miss Lynn St. George, she requires about 1966 kcals, and this was using the 450 calories for her 3rd trimester of additional calories that she needs to support the growth of the fetus, which is, this amount is a little bit lower than a normal pre-pregnancy body weight, because she is overweight, so she won't need as much. Her protein is 1.1 grams per kilograms per day, which is recommended for pregnant women, and that came out to be 88.5 grams of protein a day for her. And carbohydrates, so since she does have gestational diabetes, she needs a little bit less, and she needs about 40 to 50% of calories from carbohydrate, which came out to be 221 to 246 grams per day. And going through my intervention, I would not show her any of this. This is just kind of to give me an idea of what she needs and give me a baseline of what she's doing and what she needs to improve on. Her nutrient needs for micronutrients. These are some of the main ones that are very important to have sufficient amounts of during pregnancy. And she is on the prenatal vitamin, which is going to be supplying her with this, but she needs a sufficient amount of calcium at 1,000 to 1,300 milligrams to help the baby's bones, teeth, heart, and muscles, and nerves develop. Folic acid at 400 micrograms to prevent birth defects of the brain and spine, which we often associate that with spina bifida. That's a big one that we often hear. Iron at 27 milligrams because of the increased needs to carry blood and oxygen to the baby. Iodine at 220 milligrams to aid in the development of the baby's brain and nervous system. Zinc at 11 to 12 milligrams for the development of the baby's brain, organ, and immune system. And finally, vitamin D at 600 international units to help absorb calcium, and it's also important for the baby's bones and teeth and the regulation of the nerves, muscles, and immune system. For my diagnoses, I came up with 2. So for her, I did inadequate fiber intake related to dietary restrictions and lack of knowledge as evidenced by constipation and her stated importance of fiber-rich foods, and also food and nutrition related knowledge deficit related to new dietary requirements as evidenced by cutting out grains per interview. So this is related to her new gestational diabetes and also symptoms of constipation that are ones that I'm going to be trying to target with my intervention. So for the intervention, I will be focusing on educating her on a diabetic meal pattern. So this entails just having balanced meals, having carbohydrates, proteins, and fat at each meal, having about 3 to 4 servings of carbohydrate at meals, and 1 to 2 at snack times, just to keep that glucose regulated and normalized. Avoiding refined grains, so she kind of has this idea of avoiding all grains, even whole grains and healthy grains, and I just want to make sure that she understands the difference between the two and knows that she does need some grains in her diet, and that would especially help with her constipation and regulating her glucose. And I would provide a handout to kind of go through all of this as well, just for her as a reference. And the second thing I would be educating on is just fiber-rich foods, so whole grains and vegetables, and making sure she knows that to get enough of these 2 a day to help with her constipation. And it would also help maintain her iron levels as well if she knew that whole grains are often high in iron when they're fortified. And lastly, I would just make sure to set a goal with the client so she has something to work towards and something that we can look back on for our later sessions. To monitor and evaluate follow-up, I would check the client's progress with the established goal by asking her about her diet, and after we've already discussed the carbohydrates, and seeing if she has been able to work towards meeting that goal. And I would also monitor the symptoms of constipation to see if she has been making those changes and to see if has been any improvement. And if there were things that if she was not able to meet her goal for some reason, I would just try my best to identify any barriers and work with her to try to address them, and then I would address any other questions that she might have. Yeah, and that's all I have for today. If you have any questions, please feel free to let me know. Thanks for listening.